All right, I think we have everybody in here from the waiting room, so I'm going to get started. Thank you for joining our Lunch and Learn today. My name is Leanne McAllister, and I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. The AAP is a 93-year-old professional association for pediatricians dedicated to the health of all children. The physician members of the Nevada AAP show their commitment to the infants, children, adolescents, and young adults throughout the state of Nevada by improving access to care, legislative and community advocacy, supportive research, education of pediatric healthcare providers, and support of their fellow chapter members. Throughout today's event, I will be monitoring the chat and muting the occasional distracting open mic. And we are recording today's Lunch and Learn, and we'll be posting it on our chapter's website, which is nevadaaap.org. And now it is my pleasure to introduce one of my favorite pediatricians, Dr. Randi Lampert, who will be monitoring our event today, moderating our event today. Dr. Lampert is the Secretary Treasurer for the Nevada chapter of the AAP, as well as the chapter's chair of our Immigrant Health Committee. Dr. Lampert.
Hi, welcome. Thank you for tuning in today. We decided to host this event to help providers learn more about caring for children from immigrant families and other people that may have language needs. And not only is it legally required to provide qualified interpreters, which you're going to learn more about today, it also improves the quality of the care you're delivering to our patients. And that's why it's so important that we not only know what we're required to do, but how the best way to approach that and handle it. And that's what we hope to get out of today's session. Joining us today, we're going to have Marcia O'Malley, who is the project coordinator with Nevada Center for Excellence in Disabilities, the Family Navigation Network, and Julia Page Hensen, who is a certified healthcare interpreter and the owner and director of Cross Cultural Services. And we're going to open up the event this afternoon with some brief skits on what you should and shouldn't, or should say shouldn't and should do when working with families that are not proficient in English. So we're going to start with our first skit, which is well, you'll be able to figure out which one it is probably very quickly. Okay, I think we're ready. Good morning. What brings you to the office today?
Español, por favor.
Hola. Can little Debbie speak English?
Yes, I speak both Spanish and English.
Great, you can translate for us then. Can you ask your mom why you're here today?
Mamá, quiero saber qué estamos aquí.
Hace 2 días Debbie comenzó a sentir dolor de estómago.
She says, I don't feel good.
Cut. And now we're going to do a second skit. Oh, we need an interpreter for this patient. Let's get Marcia, our qualified interpreter, to come in with me. Good morning. What brings you to the office today?
Buenos días. ¿Qué la trae a la oficina de hoy?
Hace 2 días Debbie comenzó a sentir dolor de estómago.
Debbie has had a stomach ache for the last 2 days.
And cut. So I know those were very short skits because we're short of time, but I think it gets the point across. The first skit was things you shouldn't do. One, you should prepare before you go into the office. So you should know that you're going to need an interpreter before you walk into the room with the family, ideally. Speaking louder does not help them understand any better. You shouldn't use a child as the translator or any family member for that matter. As you could see, the child did not translate what the parent was saying. You could tell, even if we didn't do the second one, the mom talked much longer than to just say, I don't feel good. And the second skit showed using a qualified interpreter. I don't know if you could tell on Zoom, but you really want to continue your eye contact with the parent, not with, or the child, and not with the interpreter. And the same thing, the interpreter will make eye contact either with the patient, parent, or provider as they're doing, whoever they're speaking to at that time. And so with that, we are now going to turn it over to Marcia to tell us a little bit more about what she does.
Oh, thank you so much, Randy. I'm Marcia O'Malley, and I'm project coordinator with the Family Navigation Network. We are housed at the Nevada Center for Excellence in Disabilities at UNR. I work out of their Reno office, and I'm going to share my screen to share a little more detailed information about who we are and what we do.
Looks wonderful.
Good. So a little bit about me before I get into the depths of it. I am a parent to a 25-year-old man named Ian, who you see in this picture, who has Down syndrome. He also has had an additional challenge for the last year and a quarter, was diagnosed with leukemia. So we're going through an interesting journey in his treatment plan. He's doing very well. I just wanted to let you know that I have a lot of lived experience that I'm walking in the door with, as do all of our other staff. We support children and youth with special healthcare needs and their families. We are Nevada's family-to-family health information center. There is one in every state, Washington, D.C., every territory in the country, and 3 tribal communities. So we are part of a really amazingly rich network filled with folks who have created content in a number of different languages, who have supported families in a number of different ways. So we walk in the door with a lot of support for us in the work that we're doing as well. We're also part of a national network of parent-to-parent, peer-to-peer family mentors. We have just launched our Parent-to-Parent of Nevada program. We have gone through our first cohort of trained volunteer support parents, and we're very excited to be able to provide that new level of support to our families. And yeah, so that gives you kind of the big picture of where we fit into everything. We're funded by Nevada's Maternal and Child Health Title V Block Grant and a grant from the Maternal Child Health Bureau of Health Resources and Services Administration. And just an example here, Family Voices is a national organization you may be familiar with. They work on behalf of children and youth with special healthcare needs. They also are the technical assistance center for all of the family-to-family health information centers. We partnered with them this year. I wanted to give you an example of how we provide some language support. We created a virtual town hall around health equity to address the impacts of racism on children and youth with disabilities in Nevada of color. And we provided Spanish translation live for that event. We also recorded it and have had it available for viewing later. Family Voices also has a number of other resources that are available for our use, and many of them have been translated into a number of different languages, so we don't have to reinvent the wheel. And in Nevada, in case you didn't know, 15% of children under 18 have special health care needs. So we're looking at somewhere around 109,000 children. And of those children, 4.5% of their households primarily speak a language other than English. So we're looking at maybe around 6,000 families right now. That's really an important need that we need to fulfill. So as an organization, we work hard to reflect that diversity in our staff. We have 2 staff members who are bilingual in English and Spanish, another who is bilingual in remind me if I'm saying this wrong. It's the Filipino language of Tagalog. Is that right?
Correct.
And another who is bilingual in English and ASL. So we really try to provide that support in addition to being a family-centered and family-led organization. The majority of our employees are family members, but they obviously have had additional training and support to do the work that we do. So what do? We support families of children and youth with special healthcare needs as they seek healthcare information. We help to increase family and professional partnerships and alliances. We help to improve care coordination, and we work to improve healthcare outcomes and satisfaction for the families that we work with. And we do that through one-on-one family support. We also provide family-centered trainings on healthcare navigation. We collaborate with partners like you all, and we have our parent-to-parent peer support program. And we help with things specifically like application assistance with Medicaid and CHIP, information and referrals to community support programs, healthcare and service providers, family-centered healthcare decision-making, youth healthcare transition, healthcare financing options, and peer support related to healthcare navigation. And so these are 3 different ways that you can connect with us. We have a hotline that you can call directly. Anyone can make a referral. So if you are working with a family and you would like to provide a referral for them, you can do it through our hotline. You could go to our website. We have 2 different intake forms, one in English and one in Spanish. And then we also have links to our Nevada Medical Home Portal and Nevada 211, both of which have really great resources to look for online before they actually get the direct support from us. And Nevada 211, if you call them, they have operators who speak both English and Spanish. And I hope I talked fast enough. I've had 5 minutes here, so I think I did it. Here's my contact information and our URL for our website, our toll-free number 833-427-1673. Please reach out, and if we can be of any assistance to the families that you are serving. Thank you.
I was just about to give you the 1-minute warning. That was perfect. Thank you. Andy, do you want to introduce Julia?
Sure. Next, we will hear from Julia, our certified interpreter.
Good afternoon, everybody. It's an honor to share the panel with these wonderful professionals. And I have my own company, Cross Cultural Services, where I offer face-to-face certified or qualified medical interpretation services, as well as written translation services. And also I train bilingual staff to become qualified medical interpreters. Today, we're going to learn a little bit about our limited English proficient census at a state level, and also maybe the national level, federal mandates and language access, such as Title VI, Section 1557, when and how to work with an interpreter, the different modes of interpretation available, the importance of identifying the need of an interpreter and documentation, and then some research information. First of all, who is a limited English proficient individual? It's someone who has a limited ability to read, write, speak in English. These individuals are entitled to language assistance with respect to a particular type of service, benefit, or encounter. It's always fascinating to me to compare ourselves from the East Coast versus the Southwest, but here we have the 15 largest metro areas and the languages that are spoken. We see New York has about 200 languages, then followed by Los Angeles, around the same, Washington, D.C., Seattle, Phoenix, San Francisco. Nevada's not even listed there. But where we are listed is in the percentage of limited English proficient population that we have in our state, which is around 12%. And this was back in 2015. Unfortunately, government census data doesn't update very often. It's almost every 10 years. But 12% is actually pretty high. And so it's different in Las Vegas, a little bit different than versus Reno, Washoe County. In Washoe County, 10% of our population is LEP. And if you Nevada as a whole is like 11.8%, which correlates with the previous slide. Now, what about our Nevada population and our Hispanic Latino community? Let's say Nevada is, or Washoe County, I think the number at top here is wrong, but I'm gonna emphasize our Hispanic or Latino descent population. In Nevada, we have 28.5% of Hispanic or Latinos versus USA 17.8%. Languages other than English spoken at home in Nevada, 29% speak another language versus USA 20.5%. This slide right here is a little old, but I wanted to reflect a little bit about what percentage of LEP speak a certain language. So in Washoe County and Reno, Spanish is 78% spoken, 7% is Tagalog, 3% Chinese, followed by Vietnamese, and other Indic languages. In the state of Nevada, more cosmopolitan, it includes Las Vegas. We have 74% Spanish, 7% Tagalog, 5% Chinese, 2% Korean, African. I also wanted to share, maybe a lot of you may know, but in 2016, Reno became a resettlement agency for refugees. So there's over 400 refugees here in our community. And the languages that we're seeing, the immigrants are coming from Syria, so it's Arabic, and then many from India, so many different dialects. And it can be challenging to meet these needs when they come into your office or in a hospital setting. So we must be very aware of like, what is our community experiencing? What changes are occurring so that we can meet the needs of our LEP community. Title VI of the Civil Rights Act. And I'm just gonna read the middle part because it states simple justice requires that public funds to which all taxpayers of all races, colors, and national origins contribute not to be spent in any fashion which encourages, entrenches, subsidizes, or results in racial, color, or national origin discrimination. And I list an example here that any entity receiving federal funds, such as Medicare, Medicaid, Part A, B, and C, must provide qualified medical interpretation services. So how does Section 1557, or what does Section 1557 do in regards to the interpretation and facilitation of communication to our LEP population? Considering Title VI of the Civil Rights Act, it also states, and I'm going to just read the middle, it says Section 1557 is a non-discrimination modification that bans discrimination in healthcare or health coverage on the basis of race, skin, color, national origin, and in parentheses, this is the biggest change, including immigration status and English language proficiency. From this point forward is that I saw in my experience, organizations started to ensure that there are qualified interpretation services, either from face-to-face interpreters at hospital settings, or actually having also the remote interpreting services. After the pandemic, as you may have experienced, we were limiting the number of people if it was at a hospital. So we resorted to go to remote interpretation services. The beauty of remote interpretation services is that they do come, these companies offer more than 200 languages. And the most common 24/7, including American Sign Language. How does that affect interpreters? Section 1557, as of 2016, requires that interpreters must be qualified and no longer just competent bilingual staff members. And qualified means that they receive training, assessment on their interpretation skills. What type of discussions should we ensure that we work through a qualified medical interpreter? Waivers of rights, consent to treatment, treatment plans, discharge instructions, financial and insurance decisions, and end-of-life discussions. A remote interpretation encounter, an average is 10 to 15 minutes. Rather, a face-to-face, it's 15 minutes, and it can be 1 hour to 3 hours, depending on the severity of the case or the type of encounter. When can we work with someone who is not a qualified medical interpreter? Almost never. Okay, has it happened? Yes, but now that we have the tools and we know the laws, we have to try to be able to be compliant and offer the adequate services. So when can someone just who's bilingual interpret? Instructions on basic plans for the day, completion of daily activities, call for assistance conversations. I always like to share these 10 tips with providers, and I know Leanne is going to be facilitating a brochure that includes this information, but some tips is work through a qualified medical interpreter. Do not depend on children, like on this previous skit that we saw, or relatives and friends, unless it's a special circumstance. Maybe there's someone who's approaching an ER and the teenager is going to tell the front desk associate, you know what, my mother's experiencing chest pain or something like that. Yes, that's understood. But even an adult cannot be neutral, can omit, and may not know the medical terminology. And imagine putting a child or a teenager in a situation, that's a lot of burden to be able to interpret in a very, very vulnerable situation for the parent and both the child. Ensure that interpreter is appropriate for the encounter. Hold a brief meeting with the interpreter if needed. This is ideal. If you can brief the interpreter, it's wonderful because the interpreter can have a little bit of time to look up a term if a diagnosis is going to be explained to the patient and the family and the parent. Read body language during face-to-face interpretation encounter. Making eye contact is key to provider relationship. Our goal as interpreters is to make certain that the provider and the patient or parent establish a trust in the relationship. So how do I achieve this as an interpreter? I will say, provider, may I explain interpreter protocol? And I will say, I'm Julie, I will speak in the first person. I will ask you to please make eye contact with Dr. Lampert, for example. Do not with the interpreter. I'm invisible. I actually say this, I'm invisible. That way I can just make them look at each other. Speak with short phrases so that I don't omit anything. Everything being said will be interpreted. And I ask the provider to also explain that I can explain that to the parent. To the patient, talk directly to the patient using first person. Third person, I do use a third person and I will communicate. Interpreter will change to third person if I'm working with a therapist so the child can interact with therapist and not with the interpreter. Be brief and explicit. Pause after a full thought for interpretation to be accurate and complete. If you speak too long, the interpreter may not remember and include everything you said. Don't ask or say anything that you don't want the patient to hear. Speak in a normal voice, clearly and not too fast or too loudly. Avoid jargon and technical terms. Avoid idioms, technical words, or cultural references that might be difficult to translate. Be patient and avoid interrupting interpretation. What to expect when you work with a qualified medical interpreter? We abide by the standards of practice and code of ethics. We explain interpreter protocol. We speak in the first person. We carry a notepad, even our phones, because now we have access to dictionary apps, such as wordreference.com. We position ourselves where we can best promote that provider and patient look at each other, or the parent. A qualified medical interpreter will request a repetition or clarification if needed to achieve accuracy and to avoid omissions. And we will not allow side conversations. So we spoke about the remote interpreting tools that there are available. And also there's great companies that offer 90 hours of training or more to their employees. So rest assured that when you work through a remote interpreter, they are trained. But there's over the phone, there's video remote, there's telehealth, and all these interpreting tools should be at the admitting areas, nurses' desk. And again, like I mentioned, they come in more than 200 languages, of which ASL is available 24/7. Also, when you work through an interpreter, very important, document through your electronic medical chart. Here's an example of what Renown has done, is that they highlight once the patient is identified as being an LEP, they need an interpreter, it's highlighted in yellow, and then the language is described. This prompts the provider or the care team to be able to be proactive and to ensure an interpreter, especially with exotic languages or with deaf or hard of hearing. This is a report that I was able to run through one of our remote interpreting companies when I was working at Renown. And it says here that 89% was the requests for interpretation was for Spanish, and this was during the pandemic, then Mandarin, Vietnamese, Tagalog, and then American Sign Language, number 5 here in Reno. So that's a very, for me, it's very important to make sure that we do have these tools available in our offices and our practices. During the pandemic, there was no discrimination. We saw everybody. So now you see also on the bottom, Tongan, Corsican, all these languages are from the Pacific Island. They're very hard to meet. Even if an organization has partnerships with 3 main vendors for remote interpreting services, it's really hard to have those kind of interpreters available. The Pacific Island, they're not refugees. They can come and work here legally. So that's why we see these other languages. Leanne, there's this, if you can facilitate that link that I shared in the chat room, because this is a link that I like to share when I present. So, how does it feel to need an interpreter? And you can share with your practices and your team members too. If you can go ahead and do that. I don't know if I need to stop sharing mine, probably, huh?
No, I just put the link in the chat, and I'll also share it with everyone by email afterwards.
Okay, so I will just proceed. Should I share it myself? It's only 1 minute, or just continue with the slides?
You're absolutely welcome to. I'll let you know if we can't hear the volume.
Okay, let me see if I can do this. Maybe I have it right here minimized. Oh. Are you seeing anything on your end? No.
No, I think sometimes
Okay.
with Zoom, it can be tricky going from PowerPoint to YouTube.
Okay.
But if we have some time at the end, I'll try to share my screen with the YouTube.
Are you seeing what I'm seeing or no?
No, just your
No, okay.
PowerPoint.
Okay, then I'll go ahead. If you can share at the end, that will be great. Okay, so let me just go ahead and close this. What does the research say? LEP patients are at higher risk for adverse events, medical errors, misdiagnosis. Qualified medical interpreters reduce the risk for adverse events, increase patient safety, help to meet patients' needs linguistically and culturally. LEP patients are more likely to report being ignored, harder to connect with emotionally, likely to have a harder time understanding what is happening to them. And the importance of working with a qualified medical interpreter is that they're part of the team, of the multidisciplinary team. We improve patient, family, and provider satisfaction, create better health quality of care, and improve healthcare outcomes. And we help organizations remain compliant with federal mandates such as Title VI, Civil Rights Act, Section 1557, Joint Commission. And that is all. Thank you so much.
Your timing was perfect too. I was just about to give you the 3-minute warning. That's wonderful. So we're a small group. There's only about 17 of us on this call. So if you have questions for any of our panelists, I encourage you to use the Zoom raise a hand feature, and I or Dr. Lampert can call on you to ask your question. You're also welcome to put questions in the chat, and Dr. Lampert will ask them. But Dr. Lampert, I think you also prepared some questions. So Julie, if you'd stop sharing screen, we'll just go into the Q&A portion.
Leanne, did you want to show the video first? That you
Let me give it a try. Yeah, sure.
And then we'll go into questions.
So.
Doctor on that too. That's Tandoro.
Excuse me, sir. I'm so sorry. Look, she's been crying nonstop. She has a temperature of 105. I don't know what to do.
Marapedik. Vi paroles
No,
lesant.
please, just every time I feed her, she throws up. I don't know.
Vi paroles
I don't understand what you're
lesant.
saying. What are you saying? Can you just look at her? No, she's burning up. Just feel.
Faju paroles la anglan.
No, what? She's burning up. Feel her head.
Tranquilli, kananche. The mother is Askan.
What is he doing?
Do you have?
My baby, she's got a temperature of 105. Every time I feed her, she throws up. Please, can you? She's burning up. Feel her head. Please, just feel her head. Feel her head. Just someone let me in to see the doctor. No, does anyone understand what I'm saying? Please, someone help me.
8% of U.S. citizens speak limited English. For these 25 million Americans, professional interpreters can mean the difference between life and death.
Very powerful. Yes, and we'll keep that link so other people can share it as well.
Okay, so now we can go to any questions. Are there any questions from the audience to start with? Nothing yet? Okay. The first question, which I think you partially answered, but I want to be more explicit about it. This is for Julia. Can my bilingual staff interpret for me?
If they have the tools to interpret, meaning if they receive training, yes, they can interpret. So that's my answer. That's my very short answer. Let's say it's a bilingual doctor. Let's say it's a bilingual medical assistant. They can communicate directly with the patient in their preferred language. Where they're not supposed to do is actually interpret for others if they have not received the adequate training to be able to facilitate communication.
Can you explain a little bit what that training involves?
Yes. So the training, in order for someone to be qualified, they must receive a 40-hour medical interpreter training. And then these type of trainees, they are able to be assessed and then under interpretation skills, and then they can proceed with national certification. The health law this year actually says that no, they don't require to now be national certified because it's not that easy, but they can be qualified. They must be qualified.
Thank you. And for Marcia, have you dealt with families that have had situations where no interpreter was available to them? And how did that feel to them? What kind of problems came up from that?
Well, I'd have to say, we occasionally will have a situation like about a month ago, we were at a community health fair event and hadn't really done proper planning before we got there and didn't realize that the majority of the families that would be there would be Spanish speaking. And I know it will never happen again. So myself and a colleague who are both only English speakers, I speak, as you can tell, very limited Spanish from back in my college days. It's been quite a number of years. So we made our way through the day, but it was not pretty. So I came back to the office and I said, we have to change this. This has got to, we have to have a different process. So we have to be able to, do a little bit of pre-planning and make sure that we have someone who speaks the language of the families that we're going to be meeting with. So I think that's one example. We occasionally get a phone call from someone who is Spanish speaking. If we don't have someone in the office who is speaking Spanish, we'll do our best to get contact information and then connect them with a Spanish speaking person later, whether it's a staff member or if it involves, the need for a professional translator. I think I mentioned this in the chat. We've actually enlisted Julia's help for that. So we do the best we can.
Leanne, any questions yet from the audience?
Yes, we just got one in the chat. Are there examples of how medical interpretation was introduced to a particular setting recently, and what were some of the challenges, please? I think people want more real world, well, this happened to me type stories. Let's start with Julia, and then if Marcia has any, or Dr. Lampert, if you have one as well.
I think in my experience, it's a small practice, and they call me and saying, hey, are we required to offer an ASL interpreter if our clinic is less than 15 employees? There are different laws like that, but the ADA can actually sue a practice if they don't offer American Sign Language. So like I said, it's very important that we do have these access to these tools, at least remote interpretation. For me, that was the thing that popped on my mind, it was, and then this practice decided actually not to attend to the patient and refer them to a bigger clinic that had the tools. But not a lot, but with the ASL interpretation, there's actually practices can be reimbursed 50% of the cost.
And I think I'll just refer back to the assistance we received from Julia. And Julia, please chime in with details. I was not there. I've heard the story of that experience, but we had a family whose child was going through an autism diagnosis at a clinic here at UNR. And they were Spanish speaking, needed interpretation. And obviously we were not going to send our intern who speaks Spanish to go in and assist. So Julia, can you give any more details about that?
I think, I don't know if that was what the reason or what was trying to be ruled out, but I think they didn't have, I think the clinic, I don't know. I don't think I remember that one, to be honest. I remember another one through your organization where there was a specialty office and they had I think one bilingual person, but that person was not going to interpret. She was not trained, but it was for a specialist who was going to give a diagnose. So it was very important because it's a patient that needed a lot of care and chronic things going on. So it's a lifelong. So it was very important that that patient received the information of the preferred language, the parent at that instance. That's the one I remembered being called.
And I have, at my last practice, we used the language line and we had access to it where we had the video for ASL, and otherwise it was usually just voice. And one of the challenges it usually worked very well. Like you said, lots of languages, they came on, the ASL worked great. I actually had parents that they preferred it to an in-person, like they could see better on the screen. So that was all great, except we did have a challenge that there was nobody who spoke Haitian Creole. And we had patients that spoke just that dialect of Creole, and we couldn't, even on the line with their 200 people, we could not find an interpreter. So we had to, luckily it wasn't an emergent thing, we had to send them back and ask them to bring some, because we had no other place to get, please bring someone that can help interpret next time, even though we knew that wasn't the right thing, because we didn't have access to anybody that spoke that language. So that was a challenge or a problem that came up, but usually it worked very, very well.
And I'd like to add on to what Julia said about getting reimbursement if it isn't available. That can be a benefit for chapter members to contact me, because I might not know the right code or what the reimbursement is, but I certainly know, I know these people who, you know, could point me in the right direction. And if there are multiple pediatricians in Nevada that are struggling to get reimbursements that they think they are properly owed from Medicaid or different payers, we can always utilize the American Academy of Pediatrics coding hotline, which if we see a trend in codes being improperly paid from multiple different doctors, we can advocate together to make sure that you are getting reimbursed if that is available, or if that's not available, figuring out what are maybe the most cost-efficient ways for pediatricians to access things like language line.
There's another question in the chat for Julia. Julia, what is your opinion on using translating apps like Say Hi?
Yeah, if it's for common communication with a friend, it's fine. For medical encounters, absolutely not. Absolutely not, because let's say Google Translate, even for a written translation document, one word is wrong, it changes the entire meaning of the context. But not, I mean, you can download an app of Language Line, which is a very good company, but those are dedicated to this, offering interpretation services. So I think you're referring to that, Shireen, but not like Google Translate to interpret a medical encounter.
And I have another question for Julia. Can you discuss, I mean, you mentioned briefly the different options for getting an interpreter, but can you go through each one and how much each one would cost?
So it depends if it's a qualified versus a national certified healthcare interpreter. For a face-to-face interpretation, the average can be from $35 to $65, $70 an hour, minimum of 2 is the standard. So it depends on the frequency. Let's say there's someone that can block you a day or 2 days, then you lower the rate. Let's say it's someone who is sporadically once a month, so then it will be like $65 or $70, minimum of 2. The remote interpreting services, they charge per minute. And I don't know how much they charge right now at the moment, but I remember back in the day, I would see like $1.19 or even $1, depending on the frequency that the organization utilizes the remote interpreting services. So it can be you have to like decide what type of encounter is this, and are you going to use a remote interpreting service, which can actually add up to more than if you were to have a face-to-face interpreter on site, or someone who's bilingual who's qualified to interpret at your practice.
I had one of our attendees direct message me what I think is a great question. Do you have any thoughts on what age a child who is deaf needs to have an independent translator and not use the parent in the room? Is there any age where it's okay for the parent to be the interpreter?
This is me, Julia, and I'm going to answer to tackle that question. It's I never had this question, but I think it's if there's no face-to-face interpreter available, and that's what their preference is, there's a waiver that the clinic can have in place to have the parent or family member who does speak, let's say ASL or an exotic language. There is only a handful, unfortunately, in Washoe County of face-to-face ASL interpreters. So that's why it's important to have the remote interpreting tool in your practice to have access 24/7 to someone who is certified in ASL interpretation.
And I think the same family rules would apply, though, that you don't want a family member being the translator, because they're not necessarily, right, they're imposing the emotion or their own skew on the what the patient is saying. I also think so and maybe we should do another lunch and learn on this, the American Academy of Pediatrics best practices is that at a certain age, between 10 and 13, children should have alone time with the pediatrician, not for a physical exam, but just for talking time. And certainly at that point, the child would need to have their own interpreter.
I would say probably under 6 that the parent would be at, because that's the age that we start asking for assent in the clinical trial. So under 6, we don't even ask the kid if they want to be in the study. It's just up to the parent. So I would think below that age, if the parent was just translating whatever the kid said, that would be fine. But once they're old enough to kind of have their own opinion about what treatment they want or whether they want to be examined or whatever, then I would think that they would need an interpreter. But probably under 6, it's fine not to.
That seems like a reasonable guideline to me. Certainly, again, if there are chapter members that have specific questions about that, we can always find an in-state attorney to make sure that whatever office policy you come up for your clinic is in line with Nevada state law.
Are there any other questions?
No, we're actually coming up on time.
Okay, well, we want to thank everyone for attending and hopefully they learned something today. If people do have questions after the event, you can email Leanne and she will forward it on to the appropriate, whether it's for Julia or for Marcia or for me. We will be able to get back with you to answer your questions. And we also want to thank Julia and Marcia for giving their time to help us with this presentation. And thank you, Leanne, for putting it all together.
Thank you all so much. This is a great start for us to have to start this conversation. And just a reminder to physicians that you don't need to go it alone. Please always reach out to me at the chapter. And I don't always have the answer, but I do know the people to ask. So don't be shy if you need us. Thanks everyone so much.
Thank you.
Bye.